Thank you, Aisha and Michelle. I really appreciate you walking us through both the definition of additional users as well as the contraceptive dynamics and how the contraceptive dynamics can affect our understanding of additional users and our terminology around that. So I hope that all of you have absorbed some of that. I know these are technical terms and technical concepts. We are leaving quite a bit of time for questions and hopefully answers, and we'll be working to do that. You do have the question and answer box in the lower right-hand portion of your screen. We are going to collect a few questions, and while we do that, I will return to the pop quiz just to see how you all did as students. So remember, we had the question on additional users with these responses. So again, are they A, individuals who start using contraception for the first time, B, the net number of users when comparing the total number of users in a specified year and the total number of users in a baseline year, C, new clients measured using HMIS data, or D, individuals who previously stopped using contraception and begin using again. So I hope you all guessed B here, and you can see that additional users, as defined by Michelle and discussed by Aisha, are the net number of users above a baseline. So, Ceci, do we know what percentage of our respondents answered correctly? We'll follow up with that in just a minute to figure out how many of you answered correctly. But again, if you looked at a couple of these other answers, you would have understood from the discussion that individuals who start using contraception for the first time, they're often referred to as first-time users or adopters. They are not necessarily additional users. And C, data coming from HMIS systems doesn't necessarily measure an additional user. Again, it can be a new client, a new user of a method that they hadn't used in the past. And they may discontinue, so they may actually fall out after leaving that clinic, and we don't know, and therefore they are not additional users necessarily. Individuals who had previously stopped using contraception and began using again, are, depending on when they begin, are lapsed users or adopters, and so again, not necessarily the same as additional users. So these concepts are all referring to individuals, A, C, and D, rather than to an aggregate measure as we measure additional users. And I think with that, we actually have some questions on the way that we actually measure additional users. So I think we should answer those questions first. And one of the first questions is actually about the denominator, and question from Eleni Hahn. And I'm going to turn this one, I think, over to Aisha, since she's at the UN Population Division. And the question is really about what we use for our measure of women of reproductive age, and when does that change? How do we allow that to change? So Aisha or Michelle can chime in on that one. Aisha, can we hear you now again?
Yep, I hope you can hear me. So if I understand correctly, the question is about denominator and women of reproductive age. So yeah, that's absolutely correct. The UN Population Division produces estimates of the absolute number of women of reproductive age, which can be used in the calculation of additional users.
Do we change that, or how do we change that over time as they estimate that? They don't just estimate that once every several years, but how do we incorporate that?
So every couple of years, the UN Population Division releases an updated set of estimates. And I think perhaps Michelle could talk through from the perspective of Track 20 about how that is then used in the calculation of additional users for the reporting of FP 2020.
Yeah, so most countries within FP 2020 use the population projections of women of reproductive age coming from the UN Population Division. So because these are projections, they estimate the total number of women of reproductive age in each year. So our measure is accounting for the fact that between 2012 and 2016, in most countries within the FP 2020 initiative, there'll be an increase in the number of women in total that's then influencing our change in additional users and total users. We also have a handful of countries who have opted to use their own in-country produced population projections. So these are places where, as part of their annual consensus workshops, there's been agreement that rather than using the global figures, because the country has its own produced and vetted and checked estimates of population projections, that those will be used.
Thanks. A good follow-up question that we've received is from Shira Fisher. Asks, given that the denominator is constantly changing, both because of growth, also as women age in and age out, for example, is there a reason to focus on the net number rather than a percentage? So my understanding there is why do we focus on the net number of additional users versus our core indicator 2, contraceptive prevalence rate? Why don't I turn that one to Michelle to answer, and I can chime in as well.
So at the time of the first London Summit in 2012, there was interest in being able to get the movement to really galvanize behind one single global number. And so while it was recognized that at a country level, countries are often measuring their progress towards these percentages, so measuring their contraceptive prevalence rate and setting goals for their contraceptive prevalence rate in the future, that it's hard to aggregate those percentages across country. It's hard to have a meaningful single global number that we can refer to. And so by turning everything into these absolutes of additional users, it lets us all work collectively towards one global goal, recognizing that different countries will contribute differently towards that number.
And thanks. And just to add in, most of our countries don't have, at a country level, additional user goals. They focus on other measures of progress, contraceptive prevalence rate being one of them. And we have countries that range from below 5% contraceptive prevalence rate to over 60%. And to come together on a single benchmark or a single goal doesn't make a whole lot of sense. And so this is one of the ways in which, as Michelle discussed, that the global community came out with a sort of global, motivating, ambitious goal that all countries could work towards. Though each country is really has contraceptive prevalence as sort of one of the key measures that they're looking at and committing to progress on. Okay, I think there's an interesting question here that we discussed, but maybe we should get into a little bit more, and that is on discontinuation. And maybe I can turn this one to Aisha because she was discussing contraceptive dynamics, and perhaps you can talk about what is the effect of discontinuation in calculating additional users. Aisha?
Okay, thanks for that question. In terms of the calculation of additional users, because typically it's estimated using information on the number of women of reproductive age, as well as the contraceptive prevalence rate, which usually comes from household surveys. In fact, levels of discontinuation are not directly feeding into this calculation. But what's important to keep in mind is that, of course, the discontinuation that's going on in the background will, of course, be affecting the CPR at different points in time. So suppose we were looking at a country with very, very high levels of discontinuation, it could be then quite hard to see that additional user number increase over time. And in fact, some have described it as the concept of the leaking bucket, which is a sort of really helpful way of thinking about it, that you could keep serving more and more women, but if there's a leak in the bucket and you've got very high discontinuation, that's really important to take into account as well, and is going to affect the ultimate additional user numbers. So just to sort of reiterate, level of discontinuation is not a direct feeder into the measure of additional users, because additional users is calculated off the number of women of reproductive age and the contraceptive prevalence rate.
Thanks, Aisha. And just to add that we've certainly been working on understanding discontinuation through FP 2020. About a year ago, members of the PME working group and colleagues started exploring adding an indicator to our core indicator suite on discontinuation. Over the last several months, we've made a lot of progress on that, and with some final approvals, we expect that this year, at a country level, we will be reporting discontinuation rates based on DHS data and surveys, and we would be doing that by method and by reason. So we encourage people to look at the leaking bucket, to understand it. There are lots of different reasons for discontinuation, and overall it will have an impact on additional users. Michelle, I think there was someone who asked if you could just explain again the difference between new users and additional users. That's probably the most common confusion that we come across. So let's just repeat that one, because it's so important for this audience to understand it.
Great. So I think there's two pieces that are confusing when talking about new users and thinking about why they're different to additional users. So first is the issue around what we mean when we say new users, and that people define this term very differently. And sometimes you even find within a country different clinics and different service delivery points not even using the same definition consistently within a country. So if we take new users to mean first-time users, right? So women who are using contraception for the first time in their life, we could think about that as a way to measure something about increasing access to contraception and growing the number of women using contraception. But the reason that that number alone doesn't tell us the same thing as additional users is because it's really only looking at one side of the equation, right? So it's looking at women who are being added in to use, or for the first time in their lives, or if we took a measure like adopters, so capturing women who lapsed use but started again. So we're only measuring, if you remember back to that graphic, those dots sort of falling in from the top. And what we're not accounting for there are the pieces of continuation or the pieces of discontinuation. So it's likely in most cases that we would count more women who are adopting or using for the first time in their lives than the net number of additional users, because the additional users measure is taking into account those dynamics of the fact that you have some women who continue contraceptive use and some women who drop out of contraceptive use. So again, it's that we're looking at something at an individual. So an individual woman can adopt, she can change methods, she can discontinue, while additional users is really a measure at the aggregate. It's saying at the population level, how is overall contraceptive prevalence and contraceptive use changing?
Thanks, Michelle. there's been a request for citing a methodology document to show how additional users are being quantified. I'll just go ahead and answer this one because the methodology documents for additional users, there's a technical note that is available both on the Track 20 website as well as the FP 2020 Measurement Hub. So if you're looking for those resources available there, it describes in more detail, and if you want, you can get the formulas and other details that go into additional users. And if you have further questions after reading that methodology document or that technical note, we encourage you to reach out to us. So a question here, and I think this is a good next one because it really comes down to the HMIS systems. A question that asks, can we monitor additional users on a monthly or quarterly basis? I'll turn that maybe first to Michelle. You work a lot with health management information systems, which many of these people are going to be familiar with. Can you do that, or can you not do that?
It's a good question, and I think this shows the importance of thinking about both what we measure at an individual level and what we measure at an aggregate level. I would say generally that because additional users and changes in contraceptive prevalence is really kind of at this big picture population level, it's a lot harder to measure these things on a really frequent basis. That increment of a year it seems to be the right increment in reflecting on sort of how things are changing over time. But we know that it's important to be monitoring things much more frequently than that. And that's where the value of data coming out of the HMIS system on client numbers, on characteristics of those clients, on what methods they're getting, are really the key to be monitoring on that more routine basis and taking that opportunity once a year. And as countries do, as they put together their estimates for the FP 2020 core indicators, to really reflect on how all that comes together, to look at how the dynamic at the whole country level, at that population level, is shifting. So is contraceptive prevalence going up? Is the country accelerating its increase over time? Are they on track to meet their goal? All of those important questions that are really reflected on annually, supported by more often routine looking into that individual level client data.
So Michelle, my understanding then is that we can't calculate additional users directly from the HMIS systems, but they're really critical to monitoring other aspects of the system that are important to accelerating progress on contraceptives. Is that right?
Yeah, so on a more routine basis, on a monthly basis or a quarterly basis, that countries or organizations are looking at their client data or their commodity data to really have a sense of what's happening, monitor progress, respond to issues. And then on a yearly basis, we pull all that information together in our estimates of prevalence and additional users to reflect more broadly on those changes.
Thanks, Michelle. You mentioned organizational data there, and we actually have a question in here from Leah Jarvis who asks, you mentioned that models help estimate how new users contribute to additional users, or first-time users. I'm going to use that term in terms of an organization. And if an organization is trying to estimate its contribution to additional users, but only has service statistics to do so, what tools are available to help model this link? Aisha, I know that you were at Marie Stopes International and working with organizational service statistics. Can you talk a little bit about what tools MSI has used and other organizations might be using to help model this link?
Sure. So Marie Stopes International developed the tool Impact 2, which is a model which draws on data in terms of services provided or commodities provided. And the user can input this kind of information, and the model takes into account a number of assumptions with regards to discontinuation, life expectancy, and so on, to estimate the total number of users at different points in time. Another input into this model is what Mary Stopes International called the client use profile, which identifies whether clients are adopting a method, whether they are continuing use from Mary Stopes itself, or whether they're continuing use but they had been previously seen by another provider. And this information helps to make sense of the types of clients that Mary Stopes is seeing in order to estimate the contribution to national additional users. So this is just an example of a tool which draws on service provision data to help make sense of contributions nationally to additional users. And this is a very different approach to what Michelle and I have been talking about nationally and globally in terms of estimating additional users. So that's one example of a tool. It's publicly available on the MSI website. Michelle, I don't know if you want to talk at all about FPET as another model which draws on service statistics.
Yeah, so FPET is the family planning estimation tool. So this is the statistical model I mentioned earlier that was developed by Track 20 and adapted from work done by the UN Population Division. And this model allows countries to project their progress in CPR as well as some of our other core indicators. And one of the things that Track 20 has done is work to be able to incorporate routine data or service statistics into this model so that if a country hasn't had a survey in a year or two, that they can allow their annual tracking of service statistics to help inform how we think CPR is growing since that last survey. And so what this does is it's a different way. So what Aisha just described for Impact 2 is really kind of a more direct way of doing this, and especially for organizations who want to look at their contribution. So what FPET does is it lets us pull sort of nationally represented service statistics together to be able to inform how we think the national trend is changing. So again, I like to think about this as a bit of a bridge. So we know that these individual measures can't be directly compared to additional users, but tools like FPET and Impact Tool help us make a link between them. So it lets us let additional users be informed by routine individual data without directly equating the two together. And I just want to reiterate that both of these tools are available open source and publicly, and that also if you go to the additional users paper that we referenced earlier, there's a bit of a description of each of these within the paper, as well as the links of where you can find them and more information.
Just one last question then, I think, and we've talked about then the FPET model, which uses really is based on the survey data, but uses the service statistics as a signal of change. Somebody asked, what happens if you don't have a survey in 2020? And for those countries that don't have surveys in every year, what are we doing and what will we do in 2020 to calculate additional users?
Great question and a nice follow-on. So we use this FPET model to estimate contraceptive prevalence in each year after 2012. And the advantage of using this model is it lets us learn from all sorts of different information. So we have country surveys. We have, as I said, in a number of countries, these routine data going in as well to help track progress. And we also just have a lot of global learning about how contraceptive prevalence changes over time. And so what this model does is lets us make the best possible estimate for what contraceptive prevalence, or MCPR, will be in each year. And actually, the model is not just a tool to look at current prevalence, but it does let us project out into the future. So even now, we can project what we think contraceptive prevalence will be in 2020 if countries continue along their current trajectories. And so each year, as we get closer to 2020 and we add more information to the model, we're getting a better estimate not only of the current prevalence in that country, but what we think the most likely contraceptive prevalence will be in 2020.
Thanks, Michelle. I think with that, we hope that we have given you some nuggets of wisdom on the difference between additional users and a lot of the individual terms that folks are using, both at an organizational and at a country level, to look at users and their different profiles, to look at first-time users and acceptors of new methods, and new clients. We encourage you to continue to explore these concepts, to ask us questions, both when you see us through email and after reviewing the materials that we will post online after this webinar. I know that measuring and understanding the term additional users can be complicated, can be confusing, and we hope that if nothing more, you will take pause when you look at the different measures that you are working with to think through how they relate to one another, and to be careful about not equating one with the other as you're working through each day and working with your statistics. I want to thank everyone of you who joined the webinar. Specifically, also want to thank our speakers Aisha and Michelle for explaining the additional users concept, defining it, talking about contraceptive dynamics. I also want to thank my colleagues here at FP 2020, Rati Bishnoi and Cecilia, who have worked tirelessly on the logistics and the technical content for the webinar, including the graphics. This webinar has been recorded and will be posted online in the coming days, along with an infographic that we're working through today, which will help to illustrate the concepts and which you can use in your work to share these concepts and the differences among them with your colleagues. Also on the Measurement Hub website I mentioned will be the technical note on additional users, the statement from the PME working group, as well as the paper published in Global Health Science and Practice, authored by Aisha Michelle, Benjamin Bellows, and Wynne Brown. This webinar is just the first in a series of measurement webinars that we plan to host in the coming year, which we aim at improving understanding of key concepts and indicators in family planning measurement. We hope that our next one will explore the also difficult concept of demand satisfied and the SDG indicator, so stay tuned for that. And we hope to be looking later in the year at method mix more deeply. So improving measurement and data understanding is a part of the FP 2020 measurement agenda. It's carried out jointly by FP 2020 Secretariat along with the Performance Monitoring and Evidence Working Group, the Track 20 project at Avenir Health, and the many data partners who we work with. We encourage you to join our efforts on the measurement agenda and to work with us to continue to measure progress towards the FP 2020 goal.